Hello and welcome to the EMS Handoff podcast with my co-host Bradley Dean. This is David Blevins, and we are your source for all things EMS. Just us riding solo tonight, so let's go ahead and jump straight into this. Bradley Dean, another week. How are things going over in North Carolina?
Good. Spent a lot of time out in the sun this week, which is why I'm a little burnt, especially the top of my head.
I don't know if for those of y'all watching on YouTube right now, you can see, especially against this white Pursuit Company EMS Handoff hoodie, we were actually out on the lake today as well. And so I had my sunglasses on and got a little bit of the raccoon eyes going on, but it just means having fun. It's summer and the sun. It wasn't that bad out here today. And we ended up coming back off the lake a little bit early because there was some storm seemed like it was coming through. So we grabbed some food and we had to get back in time to record the EMS Handoff podcast, but we're caught a little bit of the MLB draft, trying to see how many Tennessee players got taken, Bradley. It's a little sad. We're about 20 deep and none of them got taken. So a little sad there.
Well, when they learn to play, maybe they'll get drafted.
Ouch. Spent, 3/4 of the season as the number one team in the nation. And just one game will, or I guess really two games will cut that short for you. So
trying to cut us. Squirrel finds a nut.
Wow. Well, on that, before we get any further, we'll go ahead and get into this EMS topic instead of baseball. But we'll have to see. Coming up, rising back up in football, rising up back in basketball, rising up in baseball, and Bradley can't say anything else at this point. So I'll just stop right there. So. All right. Well, first off, before we get started, we'd like to thank our podcast partner, the Journal of Emergency Medical Services. Jim's has been a great partner since we started the EMS Handoff. And since we're rebooting as well, great give there. But while EMS Handoff serves as your source for all things EMS in the podcast first, go over to Jim's for everything else. They are your source for everything else EMS that you can't get through this. And also go and you can check all of our previous episodes from the EMS Handoff, 53 other episodes at this point in time of high quality content, mischievousness, and whatever else we can get into. And so make sure to go by and check them out, gyms.com, and see what else they've got going on. Bradley, it's just us tonight. We're going to do a little roundtable and some controversial topics. I'm going to start off with saying, but and then some that probably none of us wish we would say ever again. But we talked last week about coming out of COVID-19. Even as right now the numbers are once again kind of fluctuating as they are. And as I mentioned last week, my mother told me she was positive and she's getting over her symptoms. But we're going to kind of go into another area. So I'm going to let you kick this one off. I want to take the next topic. So let's get into emerging infectious diseases.
Unfortunately, we've been dealing with some issues across the country with the emergence of monkeypox. So that's probably one of the things that we need to talk just a little bit about as we start diving into emerging infectious diseases. We've had Ebola, then we've had COVID, now we've got this whole thing with monkeypox. And one of the things to look at is we've actually got a case local where I am that we've been following a little bit. And across the country as of Friday, there were 1,470 cases across the United States, with 11 of those in North Carolina. I don't know what the case count is in Tennessee, but starting to get a little concerning with the spread. And anytime we have a transient population, people who are able to travel and do a lot of social interaction, you always get the possibility of spreading some type of virus or bacterial stuff.
Well, and I think a lot of people need to take a look. Monkeypox is not something that is new. It's something that's been around. In fact, there's vaccines for it, but it's something that is pretty much basically eradicated. We didn't see it anymore, and now we're starting to see it again. Is that correct?
Yes, and the whole part of this is we're not sure exactly where monkeypox, started, but believe that it was probably started with a type of rodent transmission over to monkeys, and then became prevalent in the population. And then at some point, anytime that you have a disease vector, and there's animals or mosquitoes or anything else, it eventually will cross into the human population, which is what happened with monkeypox. And then, while we haven't seen a lot of it in the United States, now we've got basically an endemic issue here, where we start to see this in certain populations.
First off, for some of our listeners, this is something that's kind of interesting. And so, we just literally talked about the pandemic for the last basically 2.5 years. And now you use the term endemic. Let's go into a little bit of detail between pandemic and endemic.
So, endemic, basically some type of disease or condition that's rarely found among a particular group of people or in a certain area. Primarily talking about monkeypox here. When we start looking at monkeypox, right now, typically the spread that we're seeing is basically has been the large proportion of what we see right now is cases among men who have sex with men. And at some point, it's going to cross, various types of individuals, whether it's, heterosexual, homosexual, whatever. And as that does it, it's because of prolonged contact. Like I said, doesn't necessarily have to be sexual contact, but, if you've got face-to-face contact for greater than 6 hours, any contact with body fluids from an individual who has monkeypox, there is some thought that it could be droplet transmitted in various portions of the disease process. So that's what we're talking about when we say endemic. So when we say pandemic, that's prevalent over a whole country or over the entire world. So the difference between what we've seen with COVID and with monkeypox is we've got this pretty much isolated to one group of individuals. It can become a pandemic and cross, other groups. So right now we're looking at an endemic issue with monkeypox.
And so, as you mentioned, cases as of now, as of the release of this, that's been about 2 weeks old, looking at about just shy of 1,500 cases. So you can take a look. So, if anytime we're talking about diseases like this, individuals can go to Center for Disease Control, find out some of the information, and this is no different. You can go to cdc.gov/poxvirus/monkeypox, and you can get into the information about this. And so when we're talking about viruses, let's talk about the signs and symptoms and kind of seeing what we could possibly encounter on the EMS side. So what does it look like if you are possibly seeing a case of monkeypox in your area, or may be dealing with a case of monkeypox?
Well, the symptoms of monkeypox can include a fever, headache, muscle aches, backache, swollen lymph nodes, chills, exhaustion, a rash that can look like pimples, blisters on the hand, face, inside the mouth, as well as other parts of the body like the chest, genitals. The rash goes through different stages before healing completely. So it may have pustules that are leaking a little bit of fluid, then they scab over. It may look a little bit like chicken pox, only they're isolated to one part of the body at first, whereas chicken pox is typically because of you're going to find it breaking out somewhere along the belly or somewhere else first, whereas this typically is going to be a isolated rash, and then it'll spread to the hands and other parts of the body. The incubation period for this, 7 to 14 days, but could be, can range from 5 to 21.
So a lot of times when we're talking about our assessments of our patients in the back of the ambulance, we're talking, hey, what is your recent medical history? And so if we're talking about this, we need to get back into, hey, have you been in contact with anybody? As you mentioned, as of right now, this is a prolonged exposure. So do you know of anybody that may be experiencing other signs and symptoms like this? That I know that range, we always talk about viruses being in that 7 to 14 day range, but it can be a little bit shorter or a little bit longer. And it usually is based on what your underlying wellness level is as to how long that will usually take. So get into those conversations about, basically anywhere from about 5 to 21 days prior to this incident. Could it manifest, what we've talked about, as you mentioned, with those signs and symptoms that a patient may experience, could these individuals be dealing with a life-threatening emergency associated with monkeypox?
Anytime that you have them on the inside of the mouth, that's always a little bit concerning. But most of the time, individuals that have this are going to be experiencing, some type of pain, some type of other issues. It's just really uncomfortable, unless in fact, a body system, for example, a respiratory or something else, they're probably going to recover from this and be fine. Right now, because of the history of it, we haven't seen a whole lot of deaths or anything with monkeypox in the past. So most individuals are going to be able to recover from this. It's just not a comfortable condition.
So the biggest thing is if they do experience this, they don't, they're not taking care of themselves. They may end up, anytime we deal with a virus like this, it has the potential to affect them going into sepsis, even potentially. But so let's talk about the healthcare provider themselves dealing with something like this. We're well versed in wearing a tremendous amount of personal protective equipment. I remember when the job came on, basically it was wearing gloves, and that was the only thing you dealt with. And at that point in time, people still ripped the finger out of the index or ripped the glove off the index finger so they could palpate for a suitable vein. And now what we think about as personal protective equipment may be a little bit different. So when we're talking about monkeypox, we have a high suspicion that we're dealing with a patient that may be infected with monkeypox. What are we looking for as far as personal protective equipment?
One of the biggest things is wear your gloves. And should go ahead and put on an N95 mask. There's nothing wrong with putting a surgical mask over that, just like we've been doing with COVID. Gloves, gown, that way you're avoiding any body substance that might be sprayed or spread as you're lifting, moving the patient, and eye protection. Just the basic things that you should be doing for some trauma patients or any other patient that may have the potential to splash or spill body fluids while you're dealing with them. And then if you are exposed to one, make sure you monitor yourself for fever, chills, swollen lymph nodes, or anything else that might develop following the post-exposure, and follow up with your healthcare provider.
So key thing with this, tons of lessons learned from COVID-19. And now as we start to see different things that are out there, EMS is going to be, with the front, we have shown ourselves as a front line of healthcare in the country with everything COVID related and what we've been doing. And same, it holds true for monkeypox. So if you do have that experience, make sure and take care, protect yourself, and be ready for those patients. So any last words on monkeypox, Bradley Dean?
Wear your PPE. That's the biggest thing.
And I think this is good to kind of mention, as we see the numbers right now, and, we're sitting at those just shy of 1,500 cases based on the time we recorded this. I think that it's important to kind of take a look at what we're dealing with. You take a look at the numbers, something like Ebola as well. It has the potential for being a bad outbreak. It depends on the mutations and stuff like that. And so the idea is to keep an eye on your state numbers, your local numbers, on any effect in emerging infectious diseases. I think that's one of the things that we have encountered is, when you take a look at the WHO and some of the others, they rate different diseases as, whether they're emerging or whether they're viruses of concern. viruses of interest. There's very specific categories, and now that surveillance is being done at our community levels as well. So tap into that. If you're a director, be in touch with those individuals, get some of this information and pass it out to your providers. Hey, for you, Bradley, as you mentioned, your county has identified a case within that area. So it is good to pass that on. We don't need to overreact and tell everybody, hey, every patient you're on, you need an N95 and you need to put a level A hazmat suit on. But the idea is there to be cautious, because the data collectors, basically each one of our providers can say, hey, I just potentially ran another case. So definitely something big that we need to keep an eye on. Keep that surveillance going. Keep talking about everything from your providers. Your providers should be comfortable enough to bring that information up to their supervisory staff and over to the health department, and then vice versa. So next we're going to shift gears just a little bit and go into a recent resolution that was passed that is put out currently for public comment. And we're wanting to go ahead and mention this because that public comment period, it will be coming to an end pretty soon. But the National Registry Resolution 22, Resolution 13 is one in which, and I'm just going to read part of the language here. Ultimately, National Registry acknowledges the quality EMS education is those interconnected, interdependent components, external validation, and multiple other aspects. But ultimately, they have seen the level of staffing shortage and are looking at different ways. And so they're rolling back an initiative that they did many years ago, in which any paramedic that was seeking National Registry, whether it was on their own volition or as part of the state like we have here, they would have to attend a paramedic program that was accredited by the Committee on Accreditation and CAHEP. The accreditation is actually awarded by CAHEP and reviewed by the Committee on Accreditation. And this backs that down to any CAHEP accredited institution in the process of with a letter of review or a state approved institution. And this would expand the opportunities for different entities to get into the educational realm. So if you take a look at the landscape of this topic, and there's many different individuals and organizations that are tied to this. I know the National Association of EMS Physicians is working on a comment. The International Association of Firefighters, Fire Chiefs, EMS organizations, National Association of EMS Educators, they're all positioning and placing comments. And National Association of EMS State Officials has been involved as well. And so one of the things that we are seeing with this is the question, we have a perceived staffing shortage in the EMS currently, and what are we going to do to get that back up? And the thoughts with this is, if you build it, they will come. So the more agencies that you have out there teaching, the more applicants that we're going to get. And so the question is, Bradley, what are your thoughts? Because I know you've been on the education side, you've been on the service side, and you have also been on the accreditation side. So what thoughts do you have, Bradley, on this resolution?
Well, I think one of the first things we probably need to look at is, what is accreditation? And accreditation basically takes a look at the process in which a program goes through to document, what they do, how they do it, and validation of the tests, and making sure they review all of their stuff. So that's the direction that accreditation goes. when you look at that, I will say that accredited education is credible education. And while I understand why they did the resolution, I don't think we have a shortage of providers throughout the country. I think we have a shortage of providers who are willing to work for low pay and poor working conditions.
And I think that kind of gets into the next topic that we're getting ready to get into as well, talking about the retention side, because I absolutely think that is part of the larger issue. And so, we take a look at this, and the state of Tennessee has been kind of doing, working with this through the legislature and introducing new ways for EMT and advanced EMT, or the pathways to get into the profession. And we have expanded the training centers for those levels. And one of the things that we're still experiencing is a shortage of applicants to work in the field. And I would have loved, I need to capture this and see if I can find it. I wish I would have at the time, but somebody did a study recently. I talked about it anecdotally for many, many years, that when I first got into the profession, the average lifespan of an EMT was about 5 years. If you couldn't get them to progress onto the paramedic side by that point in time, you were going to lose them. When I took this position that I'm in now, we saw those EMTs in about the 3-year window. And if we didn't capture them or get them to the paramedic level within that point in time, where they have, for lack of a better term, more skin in the game with the time and education, and like you said, we'll talk about it, but salaries and stuff like that, we would lose them at that point. And this study that was done, and I apologize, I'll try to get it for the show notes, but it actually talked about the national average was about 8 months now for an EMT. And I think one of the things you got to take a look at is, in our area, Bradley, we talk about EMS having a shortage, but right now, healthcare in itself has issues. There's a staffing issue at physicians. There's a staffing issue with nurses. I saw one area that was actually paying physicians, I think it was $122. That's what's sticking in my head, $122 an hour to actually work nursing shifts on top of their rotations as a physician, because they were so short. And one of the things we're seeing in our area is many institutions are actually hiring paramedics to work full scope of practice in a hospital's emergency department to identify some, or to offset some of their shortage. So as you mentioned, it's not whether that we have a shortage, it's where are they? And in talking, that's one of the things, we have a tremendous amount of numbers, but are they working? And on the flip side, we have several that are looking to leave the profession altogether. But so with this resolution, if we scale back, and as you mentioned, the accreditation, and anybody that's been involved with accreditation will tell you, it's a pain in the butt. There's a lot of stuff, but one of the things it does is makes you take a look at, are you doing things right? I just got done with a book, and it's called Trust-Based Leadership by Mike Ettore. And he asks 3 questions of his people. What are we doing that we shouldn't be? What are we not doing that we should be? And what are we doing that we should be doing better? And I think that's the question of those processes. When you're on the academic side, the question isn't about whether we need to get this person through because of the numbers out there. We're going, is this person qualified? Is this person capable? Is this person competent to do the jobs that they're tasked to do? And so the question is, if we scale this back and it opens up the opportunity for more paramedic education programs out there that may or may not be in following the same standards of accreditation, does that help where we are?
I really don't think that it helps where we are. I think we run into the issue of, first of all, let me just put out there a couple of things about accreditation. Um, I think it's a positive move for the profession and the right direction we need to go in order to gain the recognition in allied healthcare programs. But some people say, well, it doesn't produce a better clinician. Accreditation has nothing to do with what comes out the other side, other than documenting and showing that they have a consistent way of doing it. What comes out the other side is a direct reflection of the faculty of the program and how much a program puts into it. Accreditation overall, I think, moves us forward as far as the profession and promotes continuous quality improvement as part of that process to make a program better. So I don't know that going back to saying, well, if it's a state-approved program, it is going to benefit anybody, because I can tell you, for example, in North Carolina, and I don't want to speak for our educators or our association, but I can tell you, I don't think we're going to back down from having to have accredited programs because we just rewrote some of the administrative code in North Carolina to reflect that they have to have KHAP accreditation. If I look at what's across the country in some of the states and their recommendations for what I have to have in order to open up or start a paramedic program, minimal equipment, minimal faculty, minimal documentation is all I would have to have. I could take what I have in my car right now and a couple of mannequins, and I can open up a paramedic program somewhere by this.
And we've seen some of those locations, in our area, Bradley. We have had some institutions, not necessarily on the EMS side, but in healthcare education in general. They came in and they bring in a variety of programs. They get approved, and they start educating, and they do all these different programs themselves, and then next thing you know, they close their doors and leave individuals out without a completed program. And we've actually taken some of those individuals in and finished them up so that they weren't out. And so when you take some of these, that would be one of the things that I would look at is, what is the viability of some of those? The big thing is, like you said, just taking the things that you have and having a program. Well, if you don't have the resources to continue what you need to do, and being viable without finding more and more money, you close the door and then it doesn't do anybody any good. So I think one of the things that anybody in EMS education on any way should take a look at what this resolution is. Don't look at it emotionally. We have, we're getting ready to talk another topic here. We are starting to see more people applying to come back into the programs, which has been an issue during COVID. And we'll see that staffing come back up. There's a lot of things that we need to do, but continue on. We want to make sure that everybody's out there, that when I come through with my family, if something happens to us, we've got the best care possible. So make sure before that comment period is up to go to the National Registry and put your comments in there. That's one thing public comments are for. They're not for organizations like large groups like I talked about earlier. It's meant for everybody. Bradley, myself, Eric, anybody that's listening to this, go in and put your comments, and they'll collect those, review those, and make a final input. So third and final topic tonight, Bradley, we already started getting into it. We should have almost done this one first and then talked about registry. But retention, I think this is very, very unique. Everybody's talking about we have a recruiting problem right now. We don't have enough people coming through the doors. And I think recruiting is only one small facet of our overall concern. We've got to get more people coming in, but if we have people leaving the back door or quitting at a rate faster than we can bring them in the front door, it's not a recruiting problem, it's a retention problem. So tell me I'm wrong there. Convince me I'm wrong.
I can't convince you you're wrong, because I mean the days are long, shifts are rough, and sometimes it just doesn't seem worth it.
So right now, in 2018, I believe it was, there was a study that was done by the Georgia. It was actually written as a doctoral dissertation by now, I believe it's now the director of EMS for the state of Georgia. It was funded by the Georgia Trauma Foundation, which is actually pretty cool. The guy got his basically his doctoral dissertation funded, which is pretty neat. But the individual that wrote this dissertation, basically cleverly titled the Georgia EMS Workforce Study, and the individual went through and talked to any individual that is either leaving the profession or switching from employer to employer. And his ultimate role was to take a look at what all were the reasons why individuals were leaving the profession. And I think it was quite interesting, why they're leaving. And it would actually be more interesting now to note when, now that we've gone through COVID, if all of those still exist, even though it was only 4 years ago, I actually think that some of the causes would be more pronounced, but I think they may be a little bit different now. But, one of the things we talk about, and you've already made mention, is money. But it was quite interesting that in this study, the Georgia EMS Workforce Study, and you can Google that and go to all of his documents, money was actually sitting in like the second or third place for most individuals. I think it went down as far as fourth. And, so I think we're at a transformative part in EMS, and, Tennessee, we're celebrating our 50th year of EMS. But when we talk about healthcare, we're still basically kind of the pubescent family member within the healthcare profession. We're in the point that we're trying to find exactly where we are, and I think that's one of the things that has been causing some of these problems. So, as we take a look at it, identifying that EMS is one of the forefronts. It's the essential portion of healthcare. And being recognized as that. But yet, while we're running short staff, these individuals are running call after call after calls. So how do we start to address or identify the retention issues within our agencies? And how do we go about starting to correct that, Bradley?
Well, I mean, I think there are a couple of things that we've got to look at. Is, one, somebody goes to work for somewhere, they're usually finding a position, but they're always looking for advancement. So career is a universal reason they tend to move on. If they can't grow.
And so for those of you listening, Bradley and I are going back and forth just a little bit, but he has got a storm that is rolling through his area. I think they were here just a little bit ago. And so he's I was about to say Bradley was a little bit unstable as he pops back on here, but his internet connection is a little bit unstable. And that may just identify some of his instability, but that's a different story. Go ahead and finish where you were at.
Yeah, that's true. So, we were talking about career advancement, that's usually one of the universal things and reasons that people tend to move on. So if they can't grow where they are, they're going to go somewhere they can. So career advancement, mental health and stress and anxiety is another huge thing, talking about, my stability. So it's not for everybody. We've got to make sure that people coming in the front side as we're recruiting them have some resiliency to be able to work in the profession and move forward. So, making sure you've got a good EAP program and someone for people to kind of relate to and talk to after difficult calls.
Well, I think I think one of the things you mentioned there, if you don't mind there, it actually just came out here recently. One of the things that we have to do is set expectations kind of where they are. And on June 22nd, this is actually an EMS 1, but Daniel Swester wrote an article entitled Toxic Heroism, the Perfect Storm in EMS Recruitment. And I think this is something that we kind of have to talk about, in that, while, even though during the COVID pandemic, we were used for a lot of life-threatening emergencies, one of the things is day after day, we're not running lights and sirens to hang off the side of cliffs, upside down cars, shooting, stabbings, all that. We spend much of the time transferring patients back and forth, making sure they get to that. We're the gatekeepers of a lot of healthcare, getting them to dialysis appointments or doctor's appointments, or some other level of care. And so if we let the expectation be known, the loud cranked music, running up and down the streets, jumping off the side of buildings, etc., then you're going to lose a lot of people when they realize, hey, that's not exactly what we do.
Yeah, and I mean, so that whole piece of it is you're right. So we've also got to look at, we're not always paid for what we do. We're paid for what we may be asked to do.
And this, I know if we have some of our directors listening, there's going to be a lot of them that say, hey, we only get paid if we do this. Right now, as we were talking about just a minute ago, there's a lot of things that are changing, from mobile integrated healthcare and or community paramedicine. We're talking, but the ET3 side, the treat in place, or the alternative destination guidelines, going to urgent care clinics or standalone EDs, or even to doctors' offices versus going to the emergency department. They're like, hey, we get paid when you take them to the emergency department, so don't just treat them and release them, because we don't get paid for that. Or don't take them here because we don't get paid for that unless it's a pre-approved transfer and those kind of things. And so, this is where we got to get creative and start working with everybody to make sure that we're funded to do what we do. We're not a taxi service. We still sit under NHTSA in the Transportation Safety Administration, but we are a healthcare entity delivering medicine in austere environments, and should be funded that way as well.
Yeah, and you mentioned another thing. I hear more grumblings around the water cooler and the coffee pot about documentation. So we know that people hate to document. That is a huge downfall of the job, but that's how we bring funds back in. That's how we pay for equipment. So our personnel have to understand how important that documentation is. But I think, again, we tend to lose people because of that. They go to other professionals and they're like, oh, the documentation in nursing is just as cumbersome.
Absolutely. And for those of you all that haven't, make sure to go back and check out our documentation. I think I was with Jason. We went through quite a bit and talking about, what are the different ones and what does it take for that? And, I can tell you this, having several personal friends, and we all do, but several friends that are physicians, and they'll tell you the worst thing they have to do is the amount of documentation that they have to do every day. But they have to do it. And if they don't, they don't get reimbursed either. And, I think, when, you kind of mentioned the gossip side, and that's one of the most interesting sides. We've had quite a few conversations about that. Is, it's like, hey, I can take 5 extra minutes and do this, and we can get funded better. And then maybe this comes about and we can get that, or the other. So all right. So our EMS roundtable tonight, we had 3 really good topic areas. I personally think, first and foremost, emerging infectious diseases. Be prepared with monkeypox. Then we talk about national registry and then retention. So, Bradley, Dean, any last thoughts for you today?
The biggest thing I would say is wear your PPE, provide your public comment to the National Registry, and then the last thing is build your personal resiliency and help your fellow coworkers.
Quick and easy. That. Yeah, absolutely. I'm going to add on to that. Keep eye on what's going on in your area. It may not be monkeypox. We may be coming into your flu season or RSV season or something. And the better we are in our disinfecting. We talk about the back of the ambulances and we wipe certain things down. But through COVID, hopefully, we've gotten a little bit better. But talk to your health departments and find out what's emerging in your area. Go to the CDC or the WHO and find out what's going on in what areas. Know what's the disease of interest and concern. There's many things out there. And then I absolutely, there are things that are asked for public comment regularly. National Registry is one right now. So go take a look at 22 Resolution 13 and give your public comment. But note that there are many different things out there that are asked about. One of the things I'm talking about at a conference this week is scope of practice or the education standard updates and scope of practice. And, those documents are sent out for public comment before they ever get released. And sometimes those public comments lead to changes before a final document or final draft. Sometimes they don't. So don't be discouraged as an EMS provider. Take interest. Talk to some others, get some people together. If a group of you come together, write that as your group, but make sure and comment. And hey, find ways in your area to make sure and retain your people. There are many different ones out there. Take a look at the workforce study. It references some others that are out there, but keep an eye out for your brother and sister. There's many different things that we can do. So as we conclude this week, we always like to say that we love recording these episodes. We don't always know what you're thinking, so please make sure to subscribe, rate, and review on the GEMS platforms, but also on YouTube for us as well. Go to our Facebook page. It's probably one of our most active areas, and find us at the EMS Handoff on Facebook. You can also find us on the web at emshandoff.com. And you can reach out to Bradley and I through our socials that you can find on those sources as well. Don't forget to go by the Pursuit Company and purchase some of our EMS Handoff apparel. Our Keep Back podcast line is probably our most popular. But like I've got our hoodie on, and I'm middle of the summer, but I got a hoodie on. Just decided to wear it today. But get our original logo stuff. Go on there, click shop, scroll down, and you'll see all of the EMS Handoff gear on there as well. So from Bradley, Eric, and I, take care, stay safe, and always remember the value of your EMS Handoff.